Good afternoon. I'm Julie Rosenberg, Public Affairs Manager at the Center for Addiction and Mental Health. Welcome to a live webcast with Dr. David Goldbloom, Senior Medical Advisor at CAMH. Welcome, Dr. Goldbloom.
Thank you, Julie. Nice to be here.
Thank you. Over the next 45 minutes, you're going to be offered a very unique opportunity to ask Dr. Goldbloom any questions that you may have about depression, its symptoms, its treatments. If you are viewing this webcast on camh.ca/Ask Dr. Goldbloom, you can submit your questions below the video, or you can also use Twitter using the hashtag Ask Dr. Goldbloom. Please exercise caution when posting personal or private information that may identify you if your privacy is important to you. During this webcast, Dr. Goldbloom will be providing general medical or health information for educational and information sharing purposes. Individual medical advice cannot be provided. Dr. Goldbloom, I'd like to have the first question.
Sure.
Why is a webcast like this important?
It's important because it's just another medium in order to reach people who otherwise might not be able to ask the questions they want or get the information they need.
What I'd like to do now is go to our first question
Sure.
from one of our viewers, Jenny, who asks, are doctors relying too heavily on drugs for depression, and is a GP suitable to diagnose and prescribe medication?
Let me take the second part of that first, because family doctors are the front door for our mental health system, and they, more than anybody else, are the people who Canadians who are struggling with depression go to get understanding and to get help. And I think that our family physicians today are very well trained and well qualified to make a diagnosis of depression and to institute treatment. For some people, that may be antidepressants. For some people, it may be counseling. And for some people, it'll be a combination of the two. As to whether antidepressants are being overprescribed, I think we need to think about the fact that when you have treatments that work, people who can prescribe them get enthusiastic. Doesn't matter what it's for, whether it's for stomach pain or mood disorders or headaches or anything. And that enthusiasm is about a wish to help people to get better. And so if you look at every treatment we've had throughout medicine, there is always a vogue for prescribing that leads to sometimes overuse of a treatment. But there's a counterbalance to be made. And the counterbalance to be made is that we know that today in Canada, there are many people with depression who are not getting any help at all. And that's an intolerable situation. It's a situation we wouldn't tolerate for any other form of human suffering. So that's the paradox. Are there some people who are getting it who don't need it? Yes. And there are many people who need it who aren't getting it.
Thank you. We have another question from Jacqueline, who asks, is there any evidence-free self-recovery and depression?
You know, there's a lot of talk nowadays about recovery in general when it comes to mental health. And there's a bit of confusion about language here, because some people think about recovery as cure, and that's sort of the traditional way of thinking about recovery. I would say a more modern way of thinking about recovery is about people finding their own path, about maximizing their talent, their potential, and minimizing the intrusion of symptoms of any illness on their quality of life and their functioning. And there's no question that for some people, depression is something that goes away on its own. The problem is nobody can tell you how long that's going to take and how bad it's going to get before it goes away. There are lots of things that people can do to help themselves out of depression. And so we often recommend to people that they use some of the very excellent self-help books that are available out there to help people navigate their way through depression. But when depression becomes more severe, it's a tough journey alone. And there's always room for somebody. It could be a family physician, a psychiatrist, a counselor, a social worker, a psychologist, a peer, to help make a difference in your recovery.
Thank you. We have a question comment from John, who says his son is in his early teens and he's wondering what to look for in terms of recognizing the signs of depression in your young teenager.
Right. And of course, teenage years are a time of tremendous change anyway. So we've got to factor that into the baseline, right? That if your teenager becomes less communicative with you than he was as a preteen, well, I hate to say it, that's pretty normal. They often move into a grunting phase of communication, and then back into their 20s, they recover the ability to use full sentences. But some of the other changes that can occur are just a kind of gradual withdrawal from the things that they normally enjoy, or sleeping way more than usual, or changes in their appearance, not taking care of themselves in the same way, not being as reactive to things going on around them that normally are a source of fun or pleasure for them. I guess I would also say, though, that one of the things that helps in that identification process is a family environment, typically around the dinner table, which is where meaningful family conversation can occur with the TV off, where things like mental health are just part of the conversation because it's a common struggle for teens. It doesn't mean that every bad mood that a teenager has is a sign of depression. It doesn't mean that every time a teenager feels anxious, it's a sign of an anxiety disorder. But there has to be the climate at home where you can talk openly about these things, while at the same time respecting the fact that a teenager starts to establish his or her independence.
Very good point. We've got another question from David. His question is, what should family doctors ask to screen for depression?
Well, this actually is a question that has been subject to some scrutiny and study as to what a family doctor should ask. And it turns out that asking plainly if somebody's feeling depressed or not enjoying the things that they used to enjoy are pretty good questions, pretty good probes for depression. And it'll identify a significant number of people who are struggling with depression. But you know, it's one thing to talk about what questions do you ask, and it's another thing to talk about how do you ask that question. Do you ask it with your hand on the doorknob as you're showing the patient out of the room? Do you ask in the waiting room? Or do you ask in a confidential environment where you've created an atmosphere where you indicate to the patient, I've got time to hear what you've got to say, and I'm prepared to hear it, as opposed to saying, you're not depressed, are you? And the implication of that kind of question is, the correct answer is no. So it's about opening the door for that kind of communication.
Just have a question from Twitter. How does CAMH establish partnerships with community mental health facilities? That's a big question.
That's a big question, and it's a fair question, because no one organization can be all things to all people. CAMH is a big player in the field of mental health in Toronto, in Ontario, and even in Canada. But for us to be successful, it's necessary that we have partnerships with all kinds of agencies, community agencies that do mental health work, housing agencies, employment agencies, peer support programs. All of those have to be part of a network. One of the challenges we have in Canada is that mental health care is highly fragmented. And often we have different organizations doing the same thing and overlapping with each other instead of collaborating with each other. So really, since the creation of CAMH 15 years ago, the importance of partnership has always been there and always been an emphasis.
What I would like to do at this point is, we've got so many other questions
Sure.
coming in, is just take a little break, and I'd like to, like our viewers to see a video that we did with you a few weeks back, just about what depression is and what to look for and how to get it treated. So
Terrific.
take a look.
Depression is a condition that's very different than simply feeling sad, low, or blue. It's a recognized clinical disorder with a whole range of signs and symptoms that allow us to make the diagnosis of depression as an illness. Depression, as a clinical disorder, is something more sustained and more broad. Yes, there's an element of having a low mood, but for many people with depression, that low mood is a sense of numbness or a lack of reactivity to the things that normally bring us pleasure. There are classic disturbances in sleep, energy, appetite, concentration, memory, motivation, decision-making, and the ability to experience pleasure that are characteristic of the clinical disorder that is depression.
So we just heard Dr. Goldbloom about some of the symptoms of depression.
Right.
I think that leads into, that's a good segue for a question that we've received from a viewer who wants to know why it seems that everyone is depressed these days.
Well, I think one of the consequences of greater public awareness of depression is that more people are talking about it, and that's a good thing. But there's a problem, and the problem is the use of the word depression. Because if people want to sound more sophisticated, instead of saying they feel sad or upset, they feel depressed. To give you an example, somebody says to you, I am so depressed about the Maple Leafs. Why can't they win the Stanley Cup like I remember from the 1960s? That's not depression, all right? People may be legitimately upset or worried or fed up or anything. All right, but that's not depression. So there's a bit of semantic confusion. But the reality is, if you look at how common depression is as an illness, we're talking about a problem that affects 1 in 5 women and 1 in 10 men over the course of their lives. That's a very common phenomenon. We do not think, based on the latest evidence that's come out of Alberta, that there is any increase in the number of people who are depressed compared to, let's say, a decade ago. The difference is people are talking about it. And so suddenly you become aware of it. It has been there all along. It's had various names: exhaustion, breakdown, all kinds of approximations, because people have a kind of magical belief that if you don't name something, maybe it's not there. We saw that with cancer. People wouldn't talk about somebody having cancer because it was tempting fate somehow. The fact that people are talking about it in a more plain language way. We're seeing prominent politicians, Bob Rae, coming forward and speaking openly about his own struggle with depression. Lisa Raitt in the federal cabinet talking about her own struggle with postpartum depression. Hockey players, football players, entertainers. When people who have achieved success in life talk about their own struggles with this, it has a permissive effect, right? It allows people who are not in the limelight in the same way to feel more comfortable to talk about their own experience.
And talking about depression is what we're doing on this live web chat. If you have just joined us, you are watching Ask Dr. Goldbloom. I am joined by Dr. Goldbloom in his office at CAMH in downtown Toronto. Just wanted to remind you that if you have any questions at all, please exercise caution when posting any personal or private information that may identify you. And just to remind you that the information that Dr. Goldbloom is providing here today is for health and informational purposes only. If you've got any technical questions about your particular case, it's always good, as you say, to go for an assessment and to contact your family physician.
Correct.
We have a lot of questions coming in. We've got a question from Andy, who wants to know, what is the government doing to provide affordable psychotherapy for people suffering from mental health problems? Excellent
question, Andy, because we have a problem in our country around access to psychotherapy services. The mental health strategy for Canada that was released last year by the Mental Health Commission of Canada, a document called Changing Directions, Changing Lives, talks about the need to make psychotherapy services more freely available and publicly funded for people who need them. And we have examples in Australia and in England where family physicians are actually able to refer patients to psychologists for evidence-based cognitive behavioral psychotherapy as a treatment. We don't have that model in Canada yet. However, things are changing. And they're changing if you look at some of our family health teams here in Ontario. The multidisciplinary nature of those family health teams means that there are people on those teams now who have the time, the skills, and the training to provide time-limited psychotherapy to people in need. On the public arena, or in the public arena rather, the National Charity Partners for Mental Health has very recently made a call for the government to invest in the amount of $100 million to provide accessible psychotherapy services for children and youth. So I think that the more that the citizens of Canada voice their demand for access to these kinds of services, the more pressure there will be on government to find innovative ways to make them available and publicly funded.
Thank you. I'd like to turn now to a question from Judy, who contacted us on Facebook, and she says that she has been diagnosed now twice over the last 7 years for borderline personality disorder. She's also been diagnosed with major depression, with PTSD. She is still on depression medication. She's going for counseling and group therapy for childhood sexual abuse. So her question is, how do I know what I really have? And any advice, suggestions for the kind of medication that she should be on?
Right. And the reality is for people who've experienced childhood sexual abuse is associated with a vulnerability in adulthood to a bunch of different difficulties and problems. So it doesn't predict the path to one specific adult diagnosis, but increases your risk for things like depression, for post-traumatic stress disorder, and indeed for a more longer-term pattern of functioning called borderline personality disorder. These disorders all have treatments associated with them, and sometimes it may be the same treatment that's helpful for more than one condition. So I think that rather than try to figure out, well, which one of these do I really have, because there is substantial overlap among those three diagnoses, I think a more useful question is, what's bothering me the most right now? Forget the diagnostic categories for the moment, what are the things that are holding me back in getting somewhere in terms of my emotional health, in terms of my functioning in relationships, in work, identifying those things and making them the targets of efforts to help you is probably more fruitful than trying to find the demarcation point that separates diagnosis A from diagnosis B from diagnosis C. The other thing to remember, of course, is there's no blood test to make any of these diagnoses. They are clinical diagnoses based on the symptoms and experiences that you describe to the person making the diagnosis. They have a high reliability, which means there's a high likelihood that if you see two different clinicians, that they will come up with the same diagnosis. But that doesn't really provide you with, I think, the help that you're looking for. The help you're looking for is how can I feel better and how can I function better? And that's why I think the symptoms need to be identified. Some of them may respond to antidepressant medications. Others may respond to individual psychotherapy or group psychotherapy. So I think it's good that you're doing a combination of things to try to help yourself to get better. The challenge is it's always hard to know how much of your improvement is attributable to the pills versus individual talk therapy versus group therapy, you'll never, and to life itself beyond that. And unfortunately, that's an answer you won't know. The important thing is to focus on getting better.
Thank you, and thank you for that question, Judy. We now have a question from Nancy, who wants to know what impact does using marijuana have on depression?
Well, look, marijuana use is common, right? Especially in younger people. And there are, for most people, marijuana can be a pretty benign experience, right? But that's people who are using marijuana occasionally rather than regularly and in small amounts. One of the problems with regular heavy daily users is that they can become lacking in motivation. It can really sort of reduce them to sludge. And as a consequence, that starts to look a lot like depression. Now, some people who are highly anxious will say that, you know what, when I smoke a joint, it really takes the edge off my anxiety. That's different than depression. And in some respects, those people are not very different than those people who say, you know, I take a drink of alcohol and that takes the edge off my anxiety. The problem is that can escalate out of control. You know, that person who needs to have one drink in order to be able to enter a social situation where they're feeling very socially anxious, that can escalate into needing multiple drinks before they can walk into a room, a crowded room of people. The other caution I want to put out there about marijuana is that we now have pretty solid evidence that for people who are at high risk for a psychotic illness like schizophrenia, that, in other words, they may have an aunt, an uncle, a parent, a sibling with schizophrenia, that marijuana can, in those vulnerable individuals, precipitate psychosis. So while that's unlikely to happen for the vast majority of people who smoke marijuana, people with a family history of psychosis should really think twice about it. And that's really about managing your risks. If I told you that, you know, your father, grandfather, great-grandfather, and 3 uncles all had heart attacks at age 39, you would probably be following a heart-smart diet and exercising and avoiding some of the risks for heart disease. Similarly, if you've got a strong family history for a psychotic illness like schizophrenia, part of managing your risk would be minimizing exposure to things that increase that risk, like marijuana.
Okay, thank you. Chris has an interesting question that we hear a lot at Public Affairs at CAMH. What term is better to use, mental health or mental illness?
Chris, this is a question that I really like. And the reason I really like it is that it's a personal bugbear of mine. And what I mean by that is that we often live in the land of euphemism. We try to avoid dealing with things by dancing around them in terms of our vocabulary. I sometimes joke that the last honestly named hospital in Toronto is the Hospital for Sick Children. And, you know, it's got tremendous brand name recognition. Sick Kids as a hospital. That's why they'd never changed the name. But I suspect if they were building Sick Kids from scratch in 2013, it would be called the Child and Youth Health and Wellness Center, because they wouldn't want to mention that it's a hospital, and they wouldn't want to mention that children who are there happen to be ill. So I see all kinds of dancing around with vocabulary. Let's talk about mental illness when mental illness exists. But mental health is more than the absence of mental illness. And so maybe I need to be a little clear about that. Because positive mental health, that state of well-being, is more than not having a psychiatric illness. And there are lots of things around improving people's self-esteem, their resilience, their coping skills, their satisfaction with their lives, their sense of fulfillment that are part of positive mental health that are not part of mental illness. But when it is mental illness, I don't like to hear it described as, a mental health deficit or mental ill health or anything like that. It's mental illness.
What I'd like to do at this juncture, we've
Sure.
talked about the symptoms of depression.
Right.
What I'd like to do now is sort of a video where you're actually talking about treatments for depression.
Okay.
Watch this.
The first step in the treatment of depression is making sure that that's in fact the diagnosis. So in other words, a careful and thorough assessment to determine that depression is indeed the problem at hand. But if the depression diagnosis is confirmed, then fortunately we have a variety of treatments that can be helpful. These include various types of counseling or psychotherapy, as well as medications to relieve the symptoms of depression. But for those who seek help, the commonest first stop is the family doctor's office. And that's indeed a good place to start in terms of the necessary first step of a careful assessment to determine whether depression indeed is the problem.
Welcome back. You are watching a live web chat with CAMH's Senior Medical Advisor, Dr. David Goldbloom, from his office at CAMH in downtown Toronto. I'm Julie Rosenberg, Manager of Public Affairs at the Center for Addiction and Mental Health. And over the last 25 minutes, we have been taking your questions and comments about depression. We've got a question from Mike who wants us to explain SAD, seasonal affective disorder. Any tips on how to deal with it as we move into
Sure.
the fall and the days get a
Sure.
lot shorter?
Oh, can you think of a better acronym to describe a depression that occurs in the fall and the winter than SAD? So let me tell you a little of the history of this. This term was actually first coined 40 years ago by a researcher named Norman Rosenthal in the United States. And what he observed was a group of people whose depression seemed to occur reliably in the fall with the change in available light. Now there's this romantic idea, and it's a myth, that, wow, Christmas must be the worst time for people with depression. And it isn't. The worst time for people with depression is typically October, November, when there is a decrease in the amount of available light, and a group of people whose experience of depression is most likely to occur at that time of year. And people with seasonal depression, or SAD, have a type of depression where the symptoms can often include what we call hypersomnia, by which I mean sleeping a lot. And in fact, they enter a kind of hibernation mode. And they may also eat more than usual, which is different than people with depression who lose their appetites and may lose tremendous amounts of weight. So there's been a lot of research, including at CAMH, on understanding SAD better. That includes research on the genetics of SAD that's been done at CAMH, but also on treatments. What's going to help people to get better? And one of the innovations over the course of the last several decades in understanding and helping people with SAD has been the use of high-intensity lights. And this is not your average light bulb. This is a high-intensity 10,000 lux. That's a lot of intensity of light. That it comes in a box that you sit in front of for half an hour each morning. And we have good evidence that these light boxes can do a lot to help vulnerable people with SAD. And you don't have to stare into the light. A lot of people use that time to to read the newspaper or do a crossword puzzle, but it can make a significant difference for people with seasonal affective disorder.
Because as you say, there is a difference between being depressed and a difference between being sad.
Right. And, let me try to clarify that a little bit because, as I say, the words are often used interchangeably. And sadness is a normal human emotion. Everyone experiences sadness appropriately, particularly around times of loss or disappointment. But if you talk to people, as I have done, who've been through depression, they can tell you, usually in a heartbeat, the difference for them between feeling sad and feeling depressed. They'll say, when I feel sad, first of all, I usually know what's making me feel sad. And second of all, even though it's a horrible feeling, I usually know it's going to go away. And third, it usually does go away. When people experience depression, they typically describe it as a kind of slow, insidious onset of a feeling that isn't so much sad as it is numb, feeling unreactive to the things that normally turn their cranks, feeling that they're in a dark hole, unable to climb out of it. Or they'll describe even a physical sensation, a pit feeling in their stomach, a sense of being weighed down by an oppressive weight that inhibits them from doing things, from engaging in things. They feel like they've gone from being a participant in life to being a spectator.
Thank you. I'd like now to turn to a question from Michael, who asks, given GPs see many cases first, what's most effective to guide evidence-based care?
Well, most effective is, first of all, making the diagnosis, and increasingly family doctors are using some pretty reliable questionnaires, very short questionnaires that allow them not only to clarify the diagnosis, but more important, to gauge the severity of it. Because depression, like all disorders, exists on a continuum. Some people have mild high blood pressure and other people have really severe high blood pressure. You may need to treat both, but the treatments may differ depending on the severity. So one of the advantages of using these questionnaires is you can also use them over time to see if somebody is showing improvement. Similarly, there are what we call clinical practice guidelines, and these have been established by the consensus of experts, and we've got lots of experts, not just at CAMH, but across the country through the Canadian Network for Mood and Anxiety Treatment. And they put out national guidelines that are available to every family doctor of a sequence of steps. Start here. If this doesn't work, go there. And so it's a bit of a roadmap to helping people with depression.
Thank you. Got a question from Jill, who is asking, are people still using shock treatment for depression?
Well, Jill, the answer is yes. And not only are they using shock treatment, it is still, long after its introduction, more than 70 years ago, one of the most effective treatments in all of medicine. It is a treatment that's used primarily for people with moderate to severe depression. Typically, people try a number of antidepressants and other interventions before they have a trial of electroconvulsive or shock therapy. But I want to say that it's very different than what people's common perception is of it. I think if there's one enduring image that colors people's perception of electroconvulsive therapy, it's the movie One Flew Over the Cuckoo's Nest. And, that iconic film that itself is now close to 40 years old has endured as an influence in our society of what ECT is about. So let me, if I can, just get you to think about the following points in relation to One Flew Over the Cuckoo's Nest and ECT. In that movie, Jack Nicholson plays a person who's not mentally ill. He's simply hiding out in an asylum in Oregon. Number two, when he's given ECT, he's given it as punishment for bad behavior, not as treatment for symptoms of illness. Number three, when he gets it, you may remember there's 6 burly guys in white holding him down. He's not given an anesthetic. He's not given a muscle relaxant. In other words, he's not given any of the components of treatment that are standard for the last 40 to 50 years. And so when he has a seizure, it's a really violent seizure. The reality of ECT is A, people are asleep when they have the treatment with a general anesthetic, and B, their muscles are completely relaxed from a muscle relaxant. I can tell you that when most people witness ECT today, they say, "Is that it?" Because it looks so much different than what people are led to believe by movies and television.
Thank you. Lorraine has a very interesting question because we've been talking a lot lately about geriatric mental health. And she wants to know, she says she has read that depression can lead to Alzheimer's disease. Is this true?
Well, it's not true in the sense that depression can cause Alzheimer's disease. However, if we think of people over the age of 65, let's say between 65 and 80, the commonest psychiatric illness is not Alzheimer's disease, it's depression. And unfortunately, there's a lot of stigma about depression in the elderly, a lot of ageism. And what I mean by that is the people who say, well, if I was that old, I'd be depressed. Or if my friends were dying, I'd be depressed. Or if I was retired, I'd be depressed. The reality is that depression in the elderly is a treatable, reversible condition. And so that we shouldn't make ageist assumptions when it occurs in an older population. That being said, there are people who develop dementia, which is Alzheimer's disease is one form of dementia, where the presenting symptoms at first may not be loss of memory. The presenting symptoms in some people can be depression, so that people can become more withdrawn, more apathetic, less engaged, and it can look an awful lot like depression. That's why when we see older people with depression, we're pretty careful to screen for any subtle signs of dementia where depression might simply be the first presenting symptom. In the same way that in younger people, we might screen as well for thyroid disease when somebody comes in and says, I feel depressed, it doesn't mean they have depression. And that's why the family doctor is a good place to start, because family doctors will screen for other medical illnesses which may mimic depression. If your thyroid's not working, you don't feel, oh gosh, there's something wrong with my thyroid, or I feel like my thyroid hormone level is low. You can't feel your thyroid hormone level, but you can feel loss of energy, sluggish, you might gain weight, and you might feel depressed. And that's why it's important to have these symptoms carefully evaluated.
We are really appreciating all the questions that we're getting from our viewers. We have time for a few more questions.
Sure.
I want to take this opportunity once again to ask our viewers to please exercise caution if you're posting personal and private information that may identify you. Once again, if your privacy is very important to you. And Dr. Goldbloom, the information that you've been providing has been very educational and informative, but in terms of clinical medical advice, your advice is to see your family doctor for
Right.
specific questions.
Right.
So we've been talking about geriatric mental health. I'd like to kind of go to the other end of the
Sure.
age spectrum now. Great question from Chris, who asks, what are some of the triggers of depression to look for in young people at university who are dealing with new pressures, who are leaving home for the first time?
Right. Well, yeah, there's a lot of changes that happen when people head off to university. It is indeed for some people the first time they're away from home, away from familiar supports, the network that they had, the social network that they had in high school, especially if they've gone far away for university, is different. There's also new opportunities, new responsibilities. So it is a time of significant change, and it's also, from a biological perspective, it's entering into an age of risk where these illnesses are more likely to occur. Now, let me be clear. The vast majority of people who go to college and university do not develop a clinical depression, right? That being said, it is a vulnerable time for people, and so that's why I think you've seen certainly the Ontario Association of Colleges and Universities has now taken up the cause of mental health in a big way because they know it's an issue on college and university campuses. That's why they're starting to train up people at the college and university level, residence dons, faculty members, in things like mental health first aid, as a way of trying to identify earlier people who are struggling.
We have time for one final question, and it's from Matt, who asks, how does CAMH assist rural Canadian communities?
Great question. I think we do it through a couple of ways. Firstly, CAMH has a provincial responsibility. And so we have a team that works really in every local health integration network in the province of Ontario around mental health policy and planning. But beyond that, in terms of frontline help, CAMH has been running for a number of years now a televideo service. So much like we're having this web chat today, there is a group of clinicians here at CAMH who regularly provide consultation, clinical consultation, to communities all across Ontario and beyond, to Nunavut, where there's been a long-standing connection with CAMH. So that I think one of the beauties of technology, as we're using with this web chat today, is the opportunity to overcome some of the geographic and access barriers that Canadians face.
I know I said that was the last question. We are running out of time. I would, though, like to get a very important question in from M. Who
Sure.
writes, symptoms of depression can also appear in bipolar. How is the distinction made in a diagnosis?
Great question. Because bipolar disorder is what used to be called manic depressive illness. And to qualify, if you will, for a diagnosis of manic depressive illness or bipolar disorder, you have to have had at least one episode of mania, whether it's mild mania or moderate mania or severe mania. And let me explain what mania is. Just as sadness is a normal human emotion, so is joy, so is happiness. But somebody who is in a manic episode has a distinctively elevated mood. This is way beyond happy. This is euphoric, and it can also spill over from euphoric into highly irritable. But it's not just the mood component that makes a diagnosis of mania. There's also a marked excess of energy. It's the kind of energy that people feel coming out their ears. It can lead them to go days without sleeping, or simply getting by with 1 or 2 hours of sleep, with their thoughts racing, thinking of new possibilities, new creative ideas, talking more quickly than usual, and doing things far more impulsively than is characteristic of them. People with bipolar disorder or manic depressive illness may have one manic episode or they may have many, and they virtually always will experience episodes of depression. And in between those two extremes, those two poles of bipolar illness, they'll have periods where their mood is level and calm, neither depressed nor manic, and often with no signs or symptoms of illness.
Thank you.
You're welcome.
One more question.
That's what you said the last time.
Last time. You know what? We've got so much.
You're like
so much to get
Columbo.
to.
There's just one more thing.
From Joe. He
from
wants
Joe.
to know, how effective are support groups in alleviating symptoms of depression?
Joe, what I would say is that, without being able to put a number on it, without being able to say to you, well, they're 72.6% effective. We don't have the numbers to say that. But we do have the human experience to answer that question. Depression can be an isolating disease, a problem for people that cuts them off from others and makes them feel that nobody would want to be with them. When you're feeling bad about yourself in the context of depression, it's not unusual to ask the question, why would anybody want to affiliate with me? I'm useless. I'm worthless. I'm hopeless. I will drag other people down. All the more reason for support groups to be there to help them from their own experience and just to provide comfort, because it actually helps this person typically to know they are not alone in their experience of struggle with depression. And we've got great examples, the Mood Disorders Association, other support groups that have been a huge boon and help to people with depression. So please don't stop.
Unfortunately, we have to stop. We're coming to the end of our web chat with Dr. David Goldbloom on depression. I want to thank you, Dr. Goldbloom, for your insight on depression. It's been very informative, very educational. And I want to thank each and every one of you out there who participated with your insightful questions. We would still like to hear from you, your thoughts about this webcast, and maybe some thoughts about what topics we could cover at a future webcast or a future video. You can please post your questions. You can go to camh.ca/ask Dr. Goldbloom, or send us a question on Twitter at CAMH News, or you using the hashtag as well, Ask Dr. Goldbloom. You have been watching Ask Dr. Goldbloom. I want to thank everyone at CAMH, and of course you, Dr. Goldbloom, for joining us. I'm Julie Rosenberg. You have been watching Ask Dr. Goldbloom, a CAMH TV production.
Thank you.